forward, I would like to invite Dr. Mithun Bhartia. He is an MRCP, MRCGP from UK, practicing endocrinologist from Guwahati. He has many feathers in his cap. He is an ex-pilot scholar from Mayo Clinic USA, CCT UK, ISSDI Technology National Task Force member, and he is founder secretary Association of Clinical Endocrinologists. Welcome Dr. Mithun. He is going to talk on practical aspects, the cases that we see in our day-to-day OPD. So he is going to discuss the patients like multiple OAD failure or those on non-critical care control. Welcome Dr. Mithun.
Thank you so much, Chairperson. I'll just get my slide up. And yeah, I'm in a very difficult position today to give this talk because I've had two speakers before me, Dr. Kalyanda and Krishna sir. They have exhausted what I have to speak. It's like I've come to an exam and I just felt the question paper has changed and I'm studying, sitting in the... So I have to prepare a whole preparation on paper just now with two speaking because most of the slides are similar. So I'll try to bring something new, but most of them have been covered by my seniors who have already come and spoken in front of me, and so it's in a nice position to be as well. So it's a sponsored symposium, as we are all aware of. Now, when we are actually a patient in the hospital, why do we want the glucose to be well controlled? I think there is a concept called think glucose that happens in UK. So in UK, whenever a patient comes with diabetes, a think glucose is triggered by the nurse who is in the ward, and the referral goes to the hospital diabetologist / endocrinologist, whoever is looking after. And depending upon the severity of the trigger, he comes today or sends his nurse or sends his junior. Because we want the sugar to be in good range. Because infection will increase the sugar, and sugar will worsen the infection. And hospital is not a good place to be. Nobody likes hospital because it's a breeding ground for a lot of infections. We want the patient to be out of the hospital, especially in UK because the hospital beds are free. Here it's a different story if it's a private organization, but in a government organization you want the beds to be empty as fast as you can. Even in private organization, they make the money in the first 24 hours. The rest is just bed charges that they are making. So all the investigation tests are done in the first 1 or 2 days. So they want newer patients faster as well, and patients should not stay because they can breathe out infections that are there. So shorter hospital stays may improve patient outcomes are there. Now I'm going to put up two cases, but I'm just going to say something before I go to this slide because Dr. Shishati mentioned something. I'm just going to put my swing on that. See, when we get married, we try to find a husband and a wife, and if we think that we get the best husband and the best wife. So I was taught very early that you don't look for a best husband, best wife because you are not best. So you look for a good enough husband and a good enough wife. And that would be either best, and I come to that in the second case when I'm going to talk about it. So the case one is something which will identify very much in real life. Person's HbA1c is 11.2, not well controlled with high sugar. Admitted now with an acute complication of fever, reduced appetite, and in the season of COVID, he's got no oxygen stats and RT-PCR is positive. So he's got COVID positive, and he's already on 3 medications: glimepiride, metformin, sitagliptin. Now, interestingly, and which I'll come to the second case, generally glimepiride in India is prescribed as twice a day. You prescribe 1 milligram BD, 2 milligram BD. This is more out of habit than actual science because they work for 24 hours. So I intentionally, in this case, I put once a day, in the next case, I put twice a day. But it doesn't really, it's like when you do beta-gliptin and metformin, it's always twice a day. It comes, the pen moves very faster like that. And that's why glimepiride generally is given twice a day, though it works for 24 hours. Anyways, that was not the question I was saying. So this patient is admitted poorly controlled in summary on 3 agents, glimepiride, metformin, and gliptin. Poorly controlled diabetes, admitted with a pneumonia, with RT-PCR, you're going to start the patient IV antibiotics, steroids as well. We know this patient is already bad diabetes control, so steroids are going to make it further worse. That is that. So how do we gain glycemic control in this case? Now, Kalyan has already mentioned about intravenous sliding scale. There are two aspects I will put, so in the next few slides I will just fastly move them because they've already been covered. But when we are talking about sliding scales, every hospital has its own style of sliding scale, intravenous sliding scales. And I thought there are two kinds of sliding scales, sir. There is a dry sliding scale and there is a wet sliding scale. Wet sliding is 50 in 50 ml of saline and then you do with fluids. And otherwise, you check the sugar, itna hai to 2 unit vajo, itna hai to 4 unit vajo, which you call correction dose, and it's, talk to the juniors a lot. So I am not a real roller for correction doses. If you want to do correction doses, it should be done with the meal. So with the meal insulin only, before lunch you can add a correction dose, not in between meals, because there is a time span in which the preceding insulin is already working in the body unless the patient is very unwell. So if the patient is very unwell, a little more unwell, is not eating and drinking, then you can use intravenous sliding scale and then convert into subcut sliding scale as soon as possible, as Kalyan has already mentioned. So as this patient was started on IV antibiotics, some steroids started and some sliding scale started. The question is, what kind of intravenous sliding scale are you going to start this patient? And as I said, everybody has a different, Novo's provided me something that may not be something I would use. There's 7, and I will tell you what perhaps practically what can do while we are doing and to convert that to subcut sliding scale when we are there. Now, the targets according to this paper is 140 to 180. See, understand when we are actually looking glucometer readings, they are not perfect. If the ISO 2013 guideline says that variation up to 15% can happen. So if the sugar is less than 115 milligrams, it is more than 115%. So it's a long variation. So what we don't want in the hospital setting is a hypoglycemia. A little bit of fluctuation is allowed. So if you aim between 120 to 160, then you've got a 15% barrier on both sides. 100 to 180, you're well covered. Because that 15% variation will happen even with the newer glucometers that are there in the ISO 2013, which we actually use in most clinical practice that we are there. So that is the monitor. You can have your sliding scales in red, green and amber to keep your eye on, and the nurses can put it. So at a snapshot you can see that the sugars are going down when you are doing sliding scales if you're going to do that. You can do it, so this is 1 year starting sliding scale, you can use a bolus dose and then, find out the start and then start to make an infusion rate with the blood glucose divided by 100. Now this is one way. The fact is, doesn't matter how you start, the fact is you recheck and you modify. So that is far more important than 5 units I start or 4 units I start. It's more important that it's been assessed, and as I have never found a hospital in which sliding scale blood sugars are seen every hourly. I have yet to come across one hospital that everybody will check the sugar every 1 hourly. It generally happens 2 to 3 hours. In a non-ICU setup, one nurse is looking after 4 to 5 patients. We have to be practical in our expectations what they are going to do. So that kind of gap has to be kept into account when we are going to prescribe that. You can adjust the sliding scales, you must adjust with the sugars coming up and coming down. So we're going to flip the next few slides. Now, the ideal thing is to move the patient from the IV sliding scale to subcut sliding scale as soon as possible. And this is something which I do in clinical practice. If the patient is stable, getting stable, I put the basal insulin 1 day before into the body. So that the requirements also come down. Patients को भी जाकर नर्स सिखा देते हैं. Patient is also becoming more comfortable with the whole concept of it. And there is some kind of basal insulin, so it becomes a transition, or you kind of save a day from moving this patient about. So my practice is I do give the basal at least a day before I am planning to move it, provided there is not much of variability that are there on the sliding scale that are there, because you're not going to do. If you're going to move them from the total dose to basal bolus regimen, though they say 50%, I actually do a 10% reduction. Because it's like you have a girlfriend and then you have a new girlfriend, you don't know how the new girlfriend is going to react. So I keep on a portion and keep it 10% less, you can always titrate it up. What you don't want is a bad experience for the patient and have hypoglycemia, and nobody likes insulin. This patient already on 3 agents. So everybody generally, because diabetes in India is a familiar psychological social condition where it includes his opinion of his barber, his opinion of his servant and his servant's relative who has told him that insulin will kill his kidneys. So some weird stories already doing the rounds. So you want a good experience when you are starting, you don't want a bad experience. So I would start a little gently, low down 10 to 15%, and then you can always titrate it up based on that. Once the patient starts eating and drinking in the hospital, I have yet to come across a hospital in which the food is very yummy. Generally the food is all bad. Even in UK, the food was never good. And maybe there's a hospital that I would definitely send chefs from my hospital. Generally people eat less in hospital because they don't like the food, because most hospitals have now stopped bringing food, allowing food to come from the house. So most corporate hospitals don't allow that. And the food is very different. So in fact, the glycemia is going to be different in the house as well as when it's going to be in the hospital. And sometimes the patient does not like the food. So with a faster acting insulin, you may be able to inject it after the patient has eaten. That flexibility is very important. When a sick patient is getting better, his appetite will start improving. So it gets a better idea to know how much he is going to need for his insulin requirement. To give the insulin just after he's eaten, and he has to just help that to a certain extent, as it can be injected up to 20 minutes after the food. So this patient, it's a good story, but obviously not all the stories happen so nicely, and things are getting better and the creatinine improves and this patient has gone home. So the point is, this is something which I do well. I make sure the patient that I start the patient on in the hospital, I teach the insulin myself. So I was asked to do a nursing education program in my hospital and not in the hospital. It's a corporate hospital, big corporate hospital, and 90% of the nurses did not know how to hold the insulin pen. And if I ask 80% कि भाई आपने शुगर कम हुआ तो क्या करेंगे? सर वो हम लोग चाय बना के लेंगे, कितना चीनी डालेंगे? एक चीनी डालेंगे सर. So the basic education about how to treat hypoglycemia, how to give the insulin is hugely missing. So what I try to do is that in my patients, the hospital, the patient is taught by me and patient will inject the insulin. And that is better because the meal comes at erratic times, nurse has to look after many patients. So he injects it when he is ready to eat or when the food has come. That makes it far more thing. And a lot of patients come and say, sir, मैं insulin नहीं ले सकता, मेरे भाई को सिखा दो, मेरे बच्चे को सिखा दो. So I ask them to make a fist. I said, if you can make a tight fist, you will grab the pen and you can take the insulin. That gives you a good idea about, whether they have the stability of the hand, they don't have arthritis to kind of inject it. Even if they have problems with the ears, you can, of the eyesight, you can do click, click. Teach them to listen to the clicks of the sound in the ears, and that makes it much more easier for the transition. You may want to change the dose of what the patient is discharged. There are some guidelines to that. But I think, as I said, it doesn't matter what you discharge. The important thing is see the patient or have some mode of communication with this patient in a week's time. Because things are going to change. He may want to eat more in the house or eat less in the house. He may want to start physical activity. More important is reassess what is happening in a week's time and then adjust what's going to happen. So as I said, with this patient, the sugars became much better, as I said. So the take-home message with the case 1, I would say, is move the patient from IV to subcut. In my case, I do 24 hours before basal. I put the basal in. Teach the patient yourself and make sure his technique and hypoglycemia is given a written statement. I make sure my patient writes how he will treat a hypo with a piece of paper before he goes away. Because what you are telling, what he is understanding is very different sometimes. So I don't tell them that you don't understand. I say maybe मैं आपको गलत समझा रहा हूँ, आप मुझे बता दो कि मैं ठीक से समझाया नहीं समझाया. So that his ego doesn't get crushed. So that then I'm telling him to repeat that. So that's that. Then we've got another patient in a different way, how to look at different things. The patient who is again on 3 agents, this is glucocorticoid which I was talking about. He's got some neuropathy that is there, which are pregabalin for his pain. He's already on 3 agents. The landmark trial has already shown that if you're already on 3 agents, adding a 4th agent generally doesn't help the diabetes and you need insulin for the patient. When you're going to give insulin, people don't like insulin that we have talked about. So it's interesting that you could actually negotiate with the patient, as Dr. Shaukat has already said, with a one-setting insulin. See, I come from Assam. Assam is famous for tea. The world means tea with a dip of Assam tea. So we give you a ready-made tea. So everything is possible. And then that's the village when you're not going to come in Assam and boil the tea. So when you have a good enough wife, when you have a way of giving the insulin, which the person can take with the convenience and look after the price of sugar, because I say it's easier to change a religion in India than to change the food habit. It's very difficult. Office going people have a big bolus of carbohydrate rice before they go Assam, and at 10 o'clock they go to the office, then they have a weak lunch, and then they come at 5 p.m. and again have a good carbohydrate. So they will do that. You can talk about it, kuch kam karo, ye karo. It's a matter of negotiation of reducing the carbohydrate. They're not going to suddenly change towards on your, they will slowly, it's not going to happen one day of time, gradually, that's you will endeavor and they will endeavor, and there's some way you will reach a middle point to do that before we get down to that. So this patient was started on IDEX, which is mainly because it's important to know which his main meal is. It may be breakfast, lunch and dinner. And then he was brought back to see us again, because the aim is generally to do a stepwise therapy before insulin is initiated. If you do it earlier, you bring the glycemic load down. It's like a snake is trapped in your garden. You're going to wait for the snake to bite you, or you're going to kill the snake. High glycemic load will increase complications. We are setting that with complications. So it's better we get on top of it with a total control as fast as we can before damages happen. That is there. Now, people have all the options. I think basal bolus is the gold standard, but there is data to show that twice a day IDEX is as good as basal bolus, and you could do basal with some agents. So it's not one that this is the only way. Whichever way it is, you need to titrate it. If it's basal, then basal plus or basal plus or basal bolus. And however, a patient who's never been on insulin, does not like insulin, it's easier to negotiate one prick than to fight the battle of doing everything. This patient was on HbA1c 9.5, it was started and was got in, after a couple of months, the HbA1c is coming down. You do a 4-week pattern with every meal, and then if you see there's another rise with another meal, then you can split the IDEX gas, which was done in this case, to get a better control, and then that was titrated out, and eventually the patient's HbA1c got better. This is a good thing that happens. However, in my practice, in my life, I've been practicing diabetes for some time now. I've hardly come across a patient whose HbA1c is so close to 6.5 and he doesn't have a hypo. So I make sure my patients have a CGMS when they're coming very close to the target. That is one indication of CGMS I really use, because that gives me a good idea about whether they are having an hypoglycemic agent or not. So yeah, you have a CGMS which is better, but it may not be the case, and you may want to tweak therapy based upon when HbA1c is not gold standard. I would say there's an error in HbA1c. When we measure HbA1c, there's an error of 0.3%. So what we are seeing, there could be 0.3 more or 0.35. Nothing is 100% right. We are in somewhere in this hotel, but if this hotel is very vast, which part of the hotel? So a little bit of error is always there in HbA1c. So the other thing is we need to aim for total control of diabetes. Regarding my bladder, because as you said, I have to make a whole new presentation after 2 presentations, because a lot of things are similar. One aspect which I want to add on to, whenever you are prescribing any insulin to your patient, do not prescribe, I don't prescribe 6U or anything. I have seen one that happening in UK, when 6U was prescribed, the U looked as 0 and the person was given 60 units. I prescribed 6 as a number, no, I think 6 or whatever, Fiat or Receive or Lantus, whatever it is. I don't write units because doctors are writing is poor and nurses' interpretation can be more poor of what we have written. So it's always better to write whole numbers rather than write U or units, so that what we are trying to do, we don't do damage, more further damage with that. So with that, I'll end my talk.
Thank you, Mithun. Dear friends, we have 2 presentations. We started the session about 20 minutes late because lunch was delayed. So we will have about 15. Now we should bracket this all this time. 3:30. I can see the speakers, the eminent speakers are already there. But please bear with me for few questions which we have pre-decided questions and few that we will ask. So I'll request Dr. Alka to first start. Would you mind coming to the stage? All please. Well, let us just stand there for a minute. I'll give you a mic in the hands. Not there, right? The discussion.
So as Dr. Mithun was saying, I would carry forward. We are in the centenary year of insulin, and the quest for best insulin is still on. So right from start it was animal insulin, then human insulin, then analogs, and now we have rapid acting and ultra long acting insulin also, with the aim of best sugar control. So as all of you have done a very well talk about all this, I would like to ask Dr. Shishadri, when will you decide to titrate the dose of IDEC-ASC and split it into two?
Right, at some point of time, depending on the patient, what will happen is that you will notice that your A1Cs are slowly creeping up. This is one. Second is, if you're somebody who uses glucometer values and you look at it, you will find that your morning dose is not helping with the pre-lunch or the pre-dinner, right? Or your fasting is again increasing. And that's a call, and roughly around, in our practice, around 20 to 24 units, then you wonder whether you should start doing it twice a day. But it is really patient dependent. Again, it's a negotiation with the patient. Sometimes just making small dietary changes tides you over for a period of time. But ultimately, every patient's journey will require a second or a third insulin. And I think twice a day works for many of our patients.
I think the questioner wanted to know the dose. I think you rightly said about 24, that's 24, 26. It's
Anything more than 24 and 26, I don't do, at least personally, I don't do
He
much.
has also asked, what is the ratio of splitting? How much in the morning, evening, or depends?
So, traditionally it's 2/3, 1/3 is what people do. But these modern insulins, remember, all you're doing is to just giving that added support. So it doesn't matter, you could do 16 in the morning and then another 6 in the evening, it doesn't matter. But traditionally we are so used to doing this 2/3, 1/3 split. Kalyan, you want to add?
Yeah, I think same, Ajay is here. Ajay is, usually make it 2/3, 1/3, something like that, but it is individual. I agree with that, but you said it's individualized. Very well said. Then the question for Kalyan, the questioner wants to know regarding the flexibility. I mean, how does the flexibility of the long-acting insulin you spoke about, you said about 40 hours, 8 to 40 hours, how does it clinically benefit? What is the clinical impact? And how do you utilize it to patient's benefit? And the question he has asked is significant. Does flexibility help in inpatient management?
So two aspects. So if I'm talking about inpatient only, so outpatient definitely helps, but a small minority of patients then begin to default if you give them too much of flexibility. The vast majority, they like it that you can take it once a day, particularly for elderly people who don't have carers all the time, that they can give it at any time of the day. So that's for outpatient. For inpatient, you always need that flexibility, because the patient doesn't choose the time that they come to the hospital. They may come at 2 o'clock in the afternoon, they may come at 2 o'clock in the morning. So it is that you start the basal insulin right there. So you give it at 2 p.m. one day, and from the next day you start giving at 8 a.m. or you give it 6 p.m. when they get admitted, and the next day you start at 8 a.m. So that flexibility definitely would help.
I think Kalyan, there is a term called insulin overwhelming. They do it for the type 1, you must have heard, it is that taking insulin at the same time every day is overwhelming the patient, so that flexibility gives. I found one more thing, as you rightly said, inpatient, sometimes the patient will go for investigation. Early morning empty stomach to X-ray and all that. So there is a flexibility of time. Inpatient, lot of investigations. So that also helps, that flexibility also helps. I have another question which questioner wants to know, that the half-life being low, being longer, does the titration have to be done daily, or titration have to be done every 2 to 3 days? I mean, your practical guidance to all of us.
So, for outpatients, I originally do it between 3 days to 7 days. For inpatients, you have to do it daily, really, because the patients are there.
Yeah.
And all the long-acting insulins, whether it is Dargi 100 or Degludec or 300, I think you should do it every day in the hospital setting. The RCT between Degludec and Dargi 100, in that trial as well, they did it every day. Because you need that. You need a daily dose of adjustment. Inpatient.
Yeah, I think inpatient daily is quite good. I think I agree with you. I think one question for Dr. Mithun is the question they have asked that, we start insulin late. That Krishna said, we escalate very late. So what's your message from that point of view regarding insulin in general? Mithun, very brief answer.
Very brief answers. At the third time the patient comes to my clinic when they're oral agents, I make them inject the needle in my clinic.
You believe in saying that if 3 orals are not working, we will change
I prime them early for insulin in my opinion. So that there is no barrier, the barrier is gone. Because the fear is when you are teaching insulin, he's thinking about the pain, he's not listening to you. So when the needle is done and out, that pain is gone, now he will listen.
Dr. Mithun, one more question. Role of CGM in inpatient hyperglycemia, especially on ultra-long-acting insulin.
So there is not much of data for inpatient.
Whenever comes with you look at me, Mithun will ask me. And so that's not the question here.
Okay. So I trained with Roger when I was at Minnesota. So I don't ask for inpatient CGMS. I do a lot of OPD CGMS. I run 100 a month, but no role of CGMS in IPD.
There's one point about the inpatient CGMS. See the ones you put in, say Libre. So you take a bit of a warm-up time is required, a few hours warm-up time. I find in practice at least 6 to 8 hours warm-up time is required. You can't have that in inpatient. Second, the interesting bit about CGMS in inpatient was highlighted during the COVID era in America, where because they wanted less contact amongst the health professionals and the patients. To reduce that, they put a lot of patients on CGMS, and just by using the flash meter, they just check the blood sugar levels and adjusted the dose of insulin. During COVID era, they found it to be extremely useful. So if you have a patient who is likely to be infected, CGMS is one of the advancements.
There is a significant question regarding the steroid-induced hyperglycemia, COVID is steroid.
Yes, we don't have the case here.
COVID-induced steroid, COVID-induced oxygen lowering, and steroid-induced hyperglycemia. What is your just practical points connect one and brief?
Okay, so I cannot stop myself from saying that it is a nightmare. COVID, those who have dealt with COVID patients, diabetes and high dose steroid, it is a nightmare, absolute nightmare. Stupendous amounts of insulin doses. So what I did was, there is no guideline to suggest that. So it is basal bolus, but you need enormous amounts of insulin. And in the world, if I put IV insulin, that takes a lot of nursing time. So basal bolus, here, what I did was, the rapid acting insulin, for those patients who were requiring high dosing, I gave it breakfast, lunch, with the evening snack, and before dinner. So 4 rapid insulins, and if I use Platin 100, I invariably split them into 2, and give in the morning, give in the evening. So the advantage, you may argue with the Degludec, is that you need lower doses, so once a dose might suffice. So 6 bricks a day is sometimes what I need.
One of our colleagues, Dr. Shaukat, I don't know if he's here, he has his entire hospital, COVID hospital, and he had a lot of patients who were very severe hyperglycemia with steroids. So he used to give insulin like we give in DK, very, very rapidly to lower it down, and he said results were good. Any experience of giving the ordinary rapid acting insulin or even faster acting insulin, giving it multiple times, he said it helps.
Yeah, so I think there is the role of the faster acting aspart here, so which you can give every 4 hours really, because that's the duration of action. So as I said, I ended up giving it at least 5 bricks a day, some 4 to 5 bricks a day.
So the order is by hook or by crook, or by hook or crook.
Yes,
bring us forward.
so we threw everything, so we even metformin, sulfonylureas, we just can't get it down, it's a nightmare.
Okay, fine. I think we have 3 minutes left, so I'll invite 1 or 2 short questions from the audience. Sir, fasting high, this for Krishna, this for Kalyan, fasting high, postprandial low.
Okay, so I'll tell you a very...
There are brief answers.
Yes, I'll be very brief. So I had one patient, one you show it here, it's an outpatient, so her fasting was high and the PP was in the normal range. Then I gave basal insulin, fasting came down, but the PP also came down. So my problem was with me, not with the patient, because I didn't take proper history. So what I found was her breakfast was very little, lunch was very little, dinner time, whole family came, sat together, had a big dinner. So what I did was, I changed it to co-formulation before dinner. So you have to really look at it case-wise. Co-formulation before dinner, that tended to take care of the PP post-dinner and also got the fasting down nicely. So it is by just a small example I'm giving you.
I think yes, you could do a CGMS with a food profile.
But
In any discrepancy of fasting and PP, you do a CGMS with a food profile, you can see where the problem is.
So this actually was highlighted by the CGMS. Because when I did the CGMS, it was all everything down after dinner, whooping rice and stay high at fasting.
which has been answered. One or more question. Yes.
So am I.
But you all talk about the I can't even imagine. Okay, see, I don't know what proportionate of your patients were on your twice daily long. I don't know what happened. The term itself is wrong. If you give twice daily or is it ultra long, I don't know. What proportionate? Could you please roughly?
Okay, so what I said was, Largine you on 100, I had given it twice a day. 40% of type 1 diabetes patients were found to require Largine 200 twice a day. No, I'm coming to that. So yes, I'm answering your question.
Please.
So for type 1 diabetes, it has been seen as a pure form, you may require twice a day, Largine 100. The one which I said was specific for COVID diabetes with high dose steroids where we are really struggling, there we give twice a day. For long-acting insulin, WD, I never use it twice a day, I always use it once a day. Even then, in WD, if you use say 40 units, if you use 10 units 4 times, that will give you a similar picture than using 40 units once a day. But I'm not advocating that, I'm saying once a day. The stacking which occurs is when you are using rapid-acting insulin frequently. That is where the stacking occurs. That's a common misconception that the longer acting insulin, if you split 2 or 3 times, it will cause stacking. No, wrong.
Okay, the final question here. The thing is about cost effectiveness. Have you ever read about the number of articles which highlight about the so-called degludec? You are about degludec. You don't even have courtesy to call lactases, glargine lactase, because that was a banker sheet. Even glargine is very expensive. So many people drop out because of you people who come, you are not being paid to talk about degludec. So any talk, anybody can prescribe degludec. People drop out and they go bankrupt. So whether you are part of the solution, not be part of the problem.
Okay. So here, I'll answer your question.
Yeah.
So you have to cater it to the patient in front of you. If somebody asks me what sort of medicine you require, I will tell them, the doctor, give me the best medicine that is available. So best, I will give you this because it has the least glycemic variability or least amount of hypoglycemia. However, patient says, I cannot afford. Very well, I will give Actropid twice and Insulamab twice. A lot of patients are on it. So you have to get it in. So that is your intelligence that you have to interpret this. So what we have said here is the best regime that you can give. If you can't afford, then you have to give next best regime.
After the president, so even
Fine. So best regime.
we talk about the insulin price. See, the mafia has adopted the price. If you talk together, bring out the price. That is what I want.
And then I have to become a minister.
Okay.
No, you can only.
I think, dear friends, as Kalyan explained, that if somebody cannot afford Insulator, we have used in the government hospital day in, day out. It works very well. Dear friends, everything has to finish in time. And one of the job of Alda, my boss, and me is to hand over the session exactly. We took over 25 minutes late. We are giving back 10 minutes to you, and time is not a limiting factor. So thank you very much, Professor Krishna. As usual, thank you very much, Kalendar, and thank you, Mr. Give a big hand for all the speakers. Thank you very much.